Well, I am Steve Higgins, the director of the Vermont Center on Behavior and Health, and I want to welcome those of you who are in the audience and those of you who are with us online to the start of the 25-26 academic year lecture series. And we are starting off with a great lecture. And you see the title here, Reducing Smoking in People with Psychiatric Disorders Using Regulatory and Behavioral Interventions. And our speaker is Jennifer Tidey. She is the, you see here, Professor of Behavioral and Social Sciences, Associate Dean for Research in the Brown School of Public Health. So really great positions and highly accomplished investigator and expert in smoking and tobacco use more generally in people who have serious psychiatric conditions. So you're going to hear all about that. Jen has an excellent educational pedigree. She did, every time I have to introduce someone, even if I know them well, I learned something that either I forgot or didn't know before, but she did both her undergraduate and her graduate training at Tufts University. I knew the graduate training, but I forgot about the undergraduate, an outstanding university. And from there, she went to a postdoctoral fellowship at Harvard University in behavioral pharmacology doing preclinical research. And then she came to the University of Vermont and did a postdoctoral fellowship in clinical or human behavioral pharmacology. And I had the honor of mentoring her during that fellowship. She was a wonderful postdoctoral fellow, very productive, and I've continued to collaborate with her ever since. She has all the accomplishments you might expect, a couple hundred publications, NIH grant support throughout her career, and a fellow in multiple scientific organizations that are associated with addiction, the American Psychological Association, Society for Research on Nicotine and Tobacco, and the College on Problems of Drug Dependence. So we were in for a treat, and without any more delay, Jennifer, thanks for being with us.
Thank you. Thank you for inviting me. I'm so pleased to be here, and thank you for those of you in the audience and those online for tuning in today. And I have 57 slides, so we are just going to go. And I'm going to talk about a lot of this work that's actually started here at the University of Vermont when I was a postdoc with Steve. And I've had, as he mentioned, just, you know, the privilege of continuing to collaborate with Steve and group, so many others at UVM throughout the years. And I'm really just so grateful for that work. And these are my disclosures. So funded by grants from the NIH, some through NIH and the FDA Center for Tobacco Products. The content is solely my own, and I have no financial conflicts of interest. So we're here to talk about smoking in people with mental health conditions. You'll hear me using the MHCs a lot, or SMI for serious mental illness during this presentation. So people with mental health conditions smoke at a higher rate than those without mental conditions. This is something we've known, you know, for 25, 30 years, and it hasn't changed a whole lot, unfortunately. And when you look at who's smoking, I'm primarily going to talk about cigarette smoking in this presentation, but if you look at who's using combusted tobacco products in the US, it's overrepresented among people with mental health conditions. So still very much a problem. And people with mental health conditions tend to smoke heavily. So they're consuming a high proportion of the cigarettes consumed in the United States. So this is a graph based on data from over 20 years ago. And you can see in people, these are quit rates. So these of ever smokers who has quit smoking. So higher is better on this graph. So among these are 2020 data, people with no disorders, around 40-something%. And then you can see a lower percent of quit rates among people with mental health conditions, including people with psychosis over here, which in this data was zero, basically. So all the smokers, ever smokers, were still smoking. And this is, whoa, what did we do here? Very touchy, sorry. You're getting a preview of a lot of slides. Okay. I will try not to do that again. So these are more recent data, and you can see the situation's a little better. All of these bars are higher, a little closer to people with no disorders, but you still have very low rates of smoking cessation among people with mental health conditions. And that's not to say that treatments don't work. The last thing I want to do is leave people with the impression that treatments are ineffective in people with schizophrenia and other serious mental illness. They absolutely do work. Varenicline, bupropion, NRT, these treatments work in people with serious mental illness. You can see some citations here, and I'll show you some slides in a minute. However, access to treatments, especially medications, is still very poor. For people with serious mental illness particularly. Quit rates without medications tend to be very low, and relapse rates, unfortunately, are very high. So you have a lot of people with mental health conditions are actually motivated to quit. It looks to be just the same as people without mental health conditions, and they try quitting, but they have less success with quitting, especially when they don't have access to medication treatments. So here is an example of, this is a secondary analysis of the EAGLE study, which compared smoking cessation medications. And this analysis conducted by Eden Evans and colleagues, comparing, this is to show you that varenicline is more effective than bupropion and nicotine patch, and clearly more effective than placebo in people with psychotic disorders, people with anxiety disorders, and people with mood disorders. And this is comparing a different secondary analysis, also by Evans et al. This is in people with schizophrenia. On the left, people without psychiatric disorders, they were run in the same study. On the right, and what you can see is that these points are all lower. So the people with schizophrenia in the study had lower point prevalence abstinence, that's the y-axis. Varenicline was the most effective in people with and without schizophrenia who smoked. The other medications were intermediate in efficacy. And you can also see that people in the placebo group, especially people with schizophrenia who got placebo, those quit rates are very low. And these were people who were motivated to quit and were getting other types of support during this trial. So, and often what comes up when I talk about smoking cessation in people with mental health conditions, especially serious mental illness, is concern about neuropsychiatric side effects of medications, adverse events. And so this is to show you that side effects for the comparisons of varenicline versus placebo, bupropion versus placebo, and NRT versus placebo were not different. You know, there was not an increased risk of side effects, neuropsychiatric side effects. There was a little bit more in the among people with schizophrenia than people without in general. And that was mainly agitation. There was some, like, you know, disordered dreams we often see with these medications, but, you know, there was no medication effect. So there was an overall of slight increased risk, but not a very high risk. And so what I've been interested in is, why can't they quit? And this slide is meant to give you an appreciation that even though I'm going to mainly focus on alternative reinforcers and nicotine reinforcement, it's multi-variable, like multi-factor determining why cessation rates are lower in people with mental health conditions, including lower access to effective treatments, some of which can be addressed with proactive treatment outreach, maybe using community health workers, for example, as Eden Evans has done. Sandra Japuntich's work, Stephen Fu's work, using proactive methods to reach people who may have barriers to accessing treatments, barriers to coming into clinics, barriers to getting medications covered by insurance. So that's certainly very important. Executive functioning issues around motivation, maybe being able to have to use other types of support when you're facing stress, other coping strategies, I should say, other than smoking to deal with that. Symptom self-medication, there's some data showing that, especially in depression, that youth in depression with depression symptoms, that is associated with increased uptake and rate of smoking. And high density of smoking cues. So there have been a few studies looking at cue reactivity in the laboratory in people with schizophrenia, for example, and people without, showing very similar responses to cues, but people with serious mental illness probably have more peers to smoke, probably are around more smoking cues. So frequency of encountering cues in their environment probably plays a role. And then what I'm going to talk about more is my particular interest, which is sensitivity to nicotine reinforcement, which may be increased in people with serious mental illness, and perhaps less sensitivity or less access to alternative reinforcement that could compete with smoking. And I also want to point out that there could be different risk factors along the smoking trajectory. So you have uptake of smoking, and then the likelihood of becoming dependent, and then wanting to initiate abstinence, and then being able to maintain abstinence may be associated with different risk factors. So we've published a little bit on that. Ooh, wrong one. So I really want to focus on my area, which uses a behavioral economic framework to understand this problem. And so, as I said a minute ago, it may be that people with serious mental illness experience stronger reinforcing effects of tobacco and of nicotine particularly. And I'll show you some evidence that supports, maybe some that is slightly less supportive of that idea. And it may be that the costs, which can be defined in different ways, of smoking are reduced in this population. So starting first with the reinforcing efficacy of tobacco being enhanced. The neuropathology underlying this may be associated with serious mental illness. So we have the self-medication hypothesis, which basically hypothesizes that the neuropathology associated with schizophrenia, for example, which leads to symptoms of schizophrenia, increases smoking or other substance use in order to self-medicate those symptoms. If you're using substances to self-medicate your symptoms, this neuropathology hypothesis is different in that it hypothesizes that the neuropathology underlying schizophrenia accounts for both the symptoms of schizophrenia and increased sensitivity to nicotine and other substance reinforcement. And so people have looked at this idea in various ways. This is a study that I really like from 20 years ago, conducted by Bonnie Spring. She asked participants, very simple question: would you rather smoke or receive this other reinforcer? So it was survey items, and the other reinforcers were a variety of things like going to the movies, being with friends, having some candy, And she compared people with no psychiatric condition to people with major depression and people with schizophrenia. And what she found is that the two patient groups were more likely to choose smoking reinforcement than those other reinforcers. So that's one piece of evidence that the reinforcing effects of smoking are higher in people with serious mental illness. Oh, okay. I may need professional help. Yeah, that's a lot. I'm gonna have to go back a lot. Sorry, folks. Sorry to you online. Oh, no, I'm not there yet. Am I? Okay, here we go. What am I doing that I shouldn't be doing?
It's the mouse scrolling. Are you using that button there?
I'm just using the arrows front and back. Okay, I'll try not to do that again.
Keyboard is there to hold out. It's not that stuff.
Okay, we'll see how we go. Okay, then used a cigarette purchase task. So this is a task where you're asking people how much they would pay for cigarettes, and you're escalating the price from basically 0 to a very high level, and you're looking at the fall off in this curve. And so we have compared, this was a study done by James McKillop and I when he was a postdoc at Brown. And we compared people with schizophrenia and people without, who were equally heavy smokers. And you can see that the graphs are basically the same. There's a little bit of evidence, maybe, that the schizophrenia group, which is the circles, is higher. They're indicating that they would purchase more cigarettes when the prices are low than the people without schizophrenia, who are the squares. But those graphs, those curves fall off at the same rate. So I would say not great evidence here that people with schizophrenia are overvaluing smoking reinforcement. I then compared smoking topography. So this is how hard are you puffing, how quickly you're puffing, interval between puffs in people with and without schizophrenia. And what you can see here is that there are people with schizophrenia are taking more puffs per cigarette, and they puff really quickly, short interval between puffs. So they're increasing nicotine in the blood faster than those without. So a little more evidence in favor of the idea that smoking is more reinforcing than equally heavy smokers without schizophrenia. Okay, I didn't do that.
Sorry about that.
Yeah, maybe it's on the side.
You're on slide 17.
Okay. I think I will just use this. Okay, thank you. Okay. I've been looked at what happens. I compared the people with and without schizophrenia when they were abstinent in the laboratory and then given the opportunity to smoke after a period of abstinence. And what you can see is that although there was not much difference in craving or in withdrawal symptoms, once given the opportunity to smoke, there was a much bigger increase in smoking among the people with schizophrenia than the controls. So a little more evidence in favor of the increased smoking reinforcement. We then wanted to take this out further and look at a longer period of abstinence and then what happens when people are given the opportunity to smoke. And so we did this study that went over a 1-week period where we had people with schizophrenia again and people without who smoked about the same. And they went through a 3-day period of abstinence, and we used contingent reinforcers based on breath, carbon monoxide or CO levels to make sure that they weren't smoking during this abstinence period. We saw them twice a day. And so they had to be below a CO level of 5 in order to continue to be in the study. And they were reinforced with monetary reinforcement for meeting that criterion. And then what we did is we did a nicotine preference task where we looked at smoking very low nicotine cigarettes and regular nicotine cigarettes right after that abstinence period. And then we followed them out for a week or so to see when they would lapse in the real world. And so looking at this abstinence period, these are participants meeting our CO criterion for abstinence. The numbers show you the number of participants who met the criterion. So people in general did very well, and we retained 75 to 78% of participants through this 3-day abstinence period. And we looked at withdrawal symptoms during this abstinence period. And so what you can see is that the smokers with schizophrenia, who are in the darker blue circles, are starting off and maintaining higher levels of anxiety, restlessness, difficulty concentrating, appetite, higher appetite, insomnia, depression, and not really different on anger. But there isn't a lot of indication that they're more sensitive. The slopes don't really differ. They're very similar in the two groups. Although the people with schizophrenia start out higher, not surprisingly, given the overlap with psychiatric symptoms in general. And then craving levels equally the same. They have smokers with schizophrenia had higher levels of craving, both QSU factor 1, which is craving to smoke, and QS factor 2, which is craving to smoke in order to reduce negative affect I'm experiencing. Throughout that period, they were higher, they remained higher. And then we looked at nicotine preference before and after the 72-hour abstinence period. And what we found is no real difference in the pre-abstinence period, which is top left there. But after abstinence, there was higher preference for the nicotine-containing cigarette than the denicotinized cigarette among people with schizophrenia, again, showing some indication that nicotine may be more reinforcing in that group. And then what happened when we gave them the opportunity to smoke after a period of abstinence? What happened was that the controls had a much longer time to relapse. The people with schizophrenia shown on the bar on the left all relapsed back to smoking within a day, but the controls were able to some of them were able to maintain abstinence for a week. And so again, we think this supports the idea that smoking, especially after a period of abstinence, is just a more reinforcing, especially nicotine, more reinforcing among people with schizophrenia. And that's what's contributing to their difficulty maintaining abstinence when they try to quit. So to summarize, in this series of studies, we found that people with schizophrenia made more choices for smoking versus alternative reinforcers. That was the Bronnie Springs study I showed you. They had greater increases in smoking after brief abstinence. That was one of my early studies, more intense puff topography, and made more nicotine choices and had stronger positive mood increases from smoking after a period of abstinence. Since I focused in this work generally in people with schizophrenia, but I'm trying to broaden this out more with people with serious mental illness in general, I wanted to highlight some of Janet Audrain McGovern's work. She's followed a very similar research interest, but using different methods, although this was a laboratory study. But she looked here in people who were depression prone, that's the blue lines. So these are people with a history of depression and current depression symptoms. And the red lines are people with no history of depression and did not have current depression symptoms. And these are participants who were again given choices between smoking versus monetary reinforcement in the laboratory. And you can see that the blue lines, the heavier line is and then the lighter lines are the confidence intervals. But if you compare the middle line of the blue and the middle line of the red, the people who are depression prone were making more choices for cigarette versus monetary reinforcement than people without. I also want to switch to the other side of the story. So it's not just necessarily about the reinforcing effects of smoking, particularly nicotine, but it could also be that, you know, in these projects where we're offering people nicotine or smoking versus alternative reinforcers, maybe the alternative reinforcers are not very effective. The costs of smoking are potentially reduced in people with serious mental illness. So we can think about costs in terms of price. How much does it actually cost, as we do in the cigarette purchase task? We can also think of cost in terms of behavior. How much behavior do you have to expend? This could be lever pressing behavior, or it could be how far do you have to walk to purchase cigarettes. So people with serious mental illness may be more willing to pay for cigarettes. They may be more willing to work harder and walk farther for cigarettes than people without serious mental illness. We can also think of costs as awareness and the salience of health consequences of smoking. Maybe for people with serious mental illness, because they have so many other factors that they're contending with, those health costs maybe are not as salient for them as they are for people without serious mental illness. And we can also think of opportunity cost. So being willing to forego alternative reinforcers in order to smoke. What is the underpinning of this? Perhaps anhedonia. So anhedonia is reduced capacity for pleasure in response to normally rewarding events. It's a common feature of serious mental illness, including schizophrenia, major depressive disorder, and PTSD and other disorders. And it is associated with vulnerability to smoking initiation and relapse in both patient and non-patient populations. And you can see some citations here of leaders in our field who have studied the relationship between anhedonia and smoking. So in terms of cost, how much are you willing to pay for cigarettes? So Mark Steinberg did a study 20 years ago, and I repeated it informally recently. And we asked people, how much do you spend on cigarettes per day? And then we look at that as a percent of their monthly income. And you know, that's a very high percentage of your income that you're spending on smoking. And I looked, as I mentioned, I looked at this recently, and it was absolutely the same, that people were spending, you know, between 28 and 30% of their income purchasing cigarettes, which obviously leaves less income for covering your other needs. Another way we've looked at sensitivity or cost sensitivity is by offering alternative reinforcers. So we looked at cost in this study two ways. We looked at cost in terms of how much responding are you going to do to get the opportunity to smoke. So in some sessions, participants came in and they had to respond 50 times to get 2 cigarette puffs. And in some sessions, they had to respond over 6,000 times to get 2 cigarette puffs. And that varied, people couldn't predict it. And you can see smokers with schizophrenia and heavy smokers without psychiatric illness from a study Warren Bickel had run. And you see very similar sensitivity to cost. And another manipulation we did is what happens if you give people in some sessions an alternative reinforcer. So you can respond on the lever A for cigarette puffs, or you can respond on lever B to get a small amount of money. I think it was $0.25 in the study. And you can see that offering an alternative reinforcer reduces the responding for cigarettes, as it should do, and maybe potentially less effectively in the smokers with schizophrenia than the controls, although I can't really say that for sure because they were not, these participants were not run in the same study. We simply replicated this methods in a new study. We looked again at sensitivity to cigarette price and found that price responsivity was similar. So that doesn't really support the idea that people with serious mental illness are willing to pay more for cigarettes, at least not here. And what about awareness of health consequences? So that could be another way of conceptualizing cost, being aware of health consequences of this behavior. The cost of that behavior may make me less likely to smoke. But here you can see that when we compared controls with people with schizophrenia, that they were very similar on their awareness of negative outcomes, both my future health, I'm worried about my future health from smoking, and my immediate health, which is that negative physical scale, which is I have more trouble climbing stairs because of my smoking, and I'm worried about that. So there was not much indication from these data that people were less aware of, maybe less able to act on, but not less aware of health consequences. And going back to these data, which is the questions again of would you rather smoke or get this alternative reinforcer? It's possible that the reason why the people with major depression and people with schizophrenia were so likely to choose smoking is that they devalued those other reinforcers. So we have to find a way of increasing the efficacy of alternative reinforcers, maybe making them more salient or making them more available in order to compete with smoking. So just to summarize this section of my talk. So smokers with schizophrenia spend a large proportion of their income on cigarettes. They're more willing to forego alternative reinforcers to smoke. However, in the laboratory, we did not see any evidence that increasing the effort required to smoke or the availability of an alternative reinforcer was different in people with schizophrenia, and they were not less aware of the health consequences of smoking. I also wanted to highlight again some of Janet Audrey McGovern's work in people with depression, because I've been primarily talking about people with schizophrenia. So she's done several longitudinal studies. I'm highlighting a few here that we're looking at depression symptoms at baseline. So these are longitudinal baseline versus later in life smoking, and what mediates that relationship. And so involvement with alternative reinforcers is something that protected people with, these are young adults with depression, from developing smoking or from higher rate of smoking. Reward expectancies also mediate that relationship. So if you're an adolescent with depression symptoms and you expect smoking to be a highly effective, rewarding reinforcer, that does also mediate progression to regular smoking. And low hedonic capacity, anhedonia, is also a mediator. So there is some evidence from this line of research as well that alternative reinforcers, low efficacy or low involvement with alternative reinforcers may mediate the likelihood of becoming a smoker and difficulty quitting. So if we buy this argument, how do we change this situation? So clearly we have to either increase the cost of smoking, or we have to reduce the reinforcing efficacy of smoking. We have to make a move on one or both sides of this ratio. So how do we do that? One way of increasing the cost of smoking is by making reinforcers contingent on not smoking. So we've done studies where we provide monetary reinforcer. This work started here at UVM. We make a monetary reinforcer available for people who are abstaining from smoking, and we withhold the reinforcer when people do smoke. And we have to use a biochemical verification to objectively verify smoking or abstinence. And you can see here that it worked very well. These are smokers with schizophrenia, and those in the non-contingent group were continued to smoke as usual. Those who got contingent reinforcers, contingent upon abstinence, with or without concurrent transdermal nicotine, reduced their smoking. So I wanted to take this out further. So this is a study that looked at the effects of contingency management with and without bupropion in people with and without schizophrenia who smoked. And you can see, if you compare the orange, red, those are non-contingent, with the green, those are contingent. So you can see the effect of the contingent reinforcer. And you can also see that the medication bupropion helped enhance the effects of the contingency management manipulation in people with schizophrenia, both on urinary cotinine, so that is an objective biomarker of nicotine intake, and in self-reported cigarettes per day, where you can see it even more strikingly. Contingency management, bupropion, perhaps less effective than contingency management. So contingency management is one way that's very effective, and very effective method for reducing smoking in general, including smoking in people with schizophrenia. Another way to approach this, like I said, is trying to make cigarettes less reinforcing. How can we do that? One way of doing that is to reduce the nicotine content of cigarettes. So we've done a whole line of research on what would happen if you took a regulatory approach to reducing the nicotine content of cigarettes across the country. So you would not be able to walk into a store and buy cigarettes that were high in nicotine. All the cigarettes in the store would be very low nicotine content cigarettes. And over time, use of very low nicotine content cigarettes, although not really safer than normal nicotine cigarettes, over time, that behavior should extinguish because you're smoking, but you're no longer getting the psychoactive ingredient in cigarettes, which is the nicotine. So decreasing the amount of nicotine in cigarettes is functionally equivalent to increasing cigarette price. Yeah, so we did a series of studies on this. These are smokers without serious mental illness. This is a study by Donnie et al., where we took all comers. So these are, if you smoke and you met our criterion for smoking, including biochemical verification of smoking, and we're not interested in quitting because we were giving people cigarettes during the study, so we did not feel like we could give them to people who were actively trying to quit. And they were randomized to one of 7 cigarette conditions with cigarette dose varying across conditions. And you can see usual brand was one of the conditions. So in one of the conditions, participants were randomized to their whatever the usual brand of cigarettes were. Then we started with a very high nicotine level that was comparable to usual brand cigarettes, all the way down to 0.4 milligram per gram cigarettes, which are like 96% lower nicotine than regular nicotine cigarettes. And you can see over a period of 6 weeks that you very quickly see a separation in these curves and basically a threshold kind of situations where people who were in the 2.4 milligram per gram nicotine content of cigarette and below reduced their smoking compared to people who were at a higher nicotine content. What I then did is I did a secondary analysis of people with elevated depressive symptoms from this study. So again, participants received cigarettes for 6 weeks that were varying in nicotine content. We looked at CESD scores, that's a measure of depressive symptoms at baseline, and looked at and just compared how do people with elevated depressive symptoms do compared to people with lower depressive symptoms in responding to these cigarettes. They got cigarettes free of charge throughout the study, and we adjusted for all those covariates that you can see. And what happened was they did just fine. So people with depression who were, these are lower depression symptoms at baseline. These are people with higher depression symptoms at baseline. So these are the highest nicotine content, and these are the lower nicotine content cigarettes. And you can see very similar across the top left and top right graphs that people with elevated depressive symptoms reduce their smoking behavior in response to reduced nicotine content cigarettes. We were also worried what will happen to depression symptoms, but we did not see elevated depressive symptoms. In fact, the opposite, we saw a reduction in depressive symptoms among people who had initially high depressive symptoms who were randomized to VLNC cigarettes. I then did a study focusing on people with schizophrenia, particularly because we thought if anyone's going to have trouble with these cigarettes and potentially have psychiatric symptom elevations from switching to very low nicotine cigarettes, it's going to be people with schizophrenia, given their high rates of smoking. And so this was a separate randomized trial. It uses very similar methods, but they were all people with schizophrenia or other serious mental illness, randomized to either normal nicotine content cigarettes or very low nicotine content cigarettes for 6 weeks, and then measures throughout that 6-week period. And what happened was, again, we saw a reduction, that's the lighter blue circles, in cigarette use among people with schizophrenia who were randomized to the VLNC condition, especially in study cigarettes. We saw a great reduction. So you may wonder why the difference between total cigarettes and number of study cigarettes. What happens is everybody uses some usual brand cigarettes. We refer to it sometimes as cheating. Everybody uses some very low, some normal nicotine cigarettes throughout the study. So we did see evidence of that, certainly. But we did not, but even given that, we saw reductions in carbon monoxide, which is a biomarker of how much smoke you're inhaling. So even given the cheating, we saw overall reduction in carbon monoxide exposure. We also saw no change, if anything, a slight decrease, but really no change in psychiatric symptoms. So there was no evidence that there was, any negative untoward consequences in people with schizophrenia. We looked at product appeal. People certainly find these cigarettes less satisfying. They are less effective at reducing craving. They enjoy them less. They're less rewarding, as we would imagine, and really as we want. We don't want people to continue to use fuel-in cigarettes forever. We want them to be effective substitutes for cigarettes, but not so effective as reinforcers that people continue to use them. They're really a tool to get people to quit. And then a series of studies conducted with the VCBH group, Steve's group here at University of Vermont. We looked at very low nicotine content cigarettes in 3 vulnerable populations. One was people with depression, people with opiate use disorders, and socioeconomically disadvantaged women who were of childbearing age. This was a slightly longer study, significantly longer study, 12-week exposure to very low nicotine cigarettes or normal nicotine cigarettes or an intermediate level cigarettes. And then people were seen weekly. They were given these cigarettes free of charge, and then they were followed up. And what you can see is this is across all 3 of those vulnerable groups. So you can see that the very low nicotine cigarettes in the 2.4 are slightly higher, but also still very low nicotine content cigarette reduced total cigarette use and reduced particularly study cigarette use. And we followed this up. So I want to go back to this for a second. While certainly significant and certainly great to see a 5 to 6 cigarette per day reduction in smoking, this isn't where we want it to be. We want the cigarette use to be close to 0 or hopefully 0. So we thought that adding an alternative source of nicotine that is a non-combusted nicotine product would be a way of reducing smoking even further across these 3 populations. We did this study, and I just want to point out that it was a 16-week study in which participants were randomized to normal nicotine content cigarettes, very low nicotine content cigarettes, or very low nicotine content cigarettes plus e-cigarettes, vapes, that were either tobacco flavored only or a preferred flavor. And we did that manipulation because one of the things that the FDA is empowered to do is potentially ban flavors from vapes. So on the other hand, providing flavored vapes may make them a more effective competing reinforcer to cigarettes. So that's what we were trying to find out in this study. And what we found is that, again, in these 3 vulnerable populations, normal nicotine content cigarettes, people are continuing to smoke them. Very low nicotine content cigarettes, people smoke less, quite a lot less. Again, 6 to 7 cigarettes reduction. Adding access to e-cigarettes or vapes with normal tobacco flavor really didn't change that very much. But giving people access to preferred flavor e-cigarette products really did change that situation. So people are now getting very close to 0, from 20 to down to 6 or 7 cigarettes per day. Again, not exactly where we want to see it. We want to see it at 0, but certainly headed in the right direction, and suggests that providing an alternative reinforcer along with reducing the reinforcing efficacy of cigarettes is an effective way of reducing smoking in people, again, with serious mental illness and other vulnerable populations. These are some biomarkers just to show you, because we collect them. And so very low nicotine content cigarettes, people had lower breath CO levels, lower NNAL, which is a tobacco not a metabolite, but a tobacco toxicant, and annotabine, and lower cotinine, which is a nicotine metabolite. Okay, so I've been trying to build the argument that behavioral economics framework is a very useful framework. By no means the only framework, but a useful framework by which to think about smoking in people with serious mental illness and what to do about it. I think a lot of our very carefully controlled research studies show that people with schizophrenia and depression are more sensitive to tobacco reinforcement, potentially nicotine reinforcement than people without these disorders, and potentially less sensitive to alternative reinforcers. And so the ways you can address this are, for one thing, reducing the nicotine content of cigarettes through regulation to make them a less effective reinforcer, providing incentives contingent upon abstinence to make not smoking a more effective reinforcer, and increasing the availability and efficacy of alternative reinforcer. So I have left time for questions, and I want to acknowledge my colleagues at Brown University who've been really crucial to this work. I was lucky to work with 2 tobacco centers of regulatory science. One, the Scenic Center, funded to Eric Donnie and Dorothy Hatsukami, where a lot of this work was done through, and through Stephen Higgins here at UVM, where a lot of this work, especially those last 2 studies, were conducted through. And thank you for your attention.
Thanks for that excellent presentation, Jen, and we have lots of time for Q&A. So Mark. Identify yourself.
Hey, wonderful presentation. My name's Mark Feinstein. I'm Eli Klemper's 5th-year grad student and trainee at the VCBH. One thing that stands up to me about both schizophrenia and depression is that both of those are diseases or disorders, or more correctly, with cyclical symptom presentations. There's times of remission, and then there's times of active psychosis or a more severe depressive episode. Have you ever taken into account kind of current or recent past symptom severity in terms of how that might influence nicotine valuation? I just have a hunch that if you're in the midst of a depressive episode, or if you have the prodromal symptoms, or you're just recovering from an active psychotic episode, that makes the more reliable reinforcement from a chemical, from nicotine, much more valuable, much more sought after.
I think that makes a lot of sense. I haven't looked at that, and I don't know anybody who has. I think one thing going against that is, we've been talking this morning with Eli and Steve about how persistent tobacco use is, and how that behavior, you can see even in the absence of nicotine, people are still smoking. So that would be sort of the counter argument, that the behavior itself is so persistent and so hard to move that it may persist even though through fluctuations. But I can't answer your question really, although it's a very interesting idea.
Other questions, comments? Yeah, Eli.
Thanks for a great talk. Eli Klemper, University of Vermont. So my question is about the role of alternative non-combusted products in the absence of very low nicotine cigarettes. I wonder if you have thoughts on potential effectiveness of switching people from combusted to non-combusted products, and whether you think that would be differentially effective among people with mental health conditions.
I think Sarah Pratt has done those studies at Dartmouth, looking at e-cigarette effects in people with schizophrenia. They were pretty effective. Yes, very effective. I don't know that there was a comparison in that study, but it is an interesting idea of and then you could try to figure out, is it the nicotine? Is it the, there are so many ways you could go with that question, but It's very interesting. But e-cigarettes on their own do seem to be an effective way of reducing smoking in people with schizophrenia.
Chris, any online?
Oh, we don't have any online, but Julia says thank you very much for the wonderful talk.
Oh, well, thank you, Julia.
Jennifer, I'm wondering, could you go back to your slides with Eden Evans' slide
Sure.
where you had on one side people with schizophrenia were treated with a number of different
Yep.
smoking cessation medications, and
We'll go back in time. It's pretty close.
it's a very powerful slide, and sorry.
No, don't be sorry. Here we.
Yeah.
You want
know,
this one or?
Yeah, no, the first one.
Yeah.
So
it's
what
very-
I was thinking is you could do a study to see, because we know people with schizophrenia or other serious mental illness do respond to contingencies. Like what would you have to add on the left to get
Right.
equivalence on the right? So if you want the equivalence of a varenicline response in people with schizophrenia, you'd have to have CM at a certain level. And, if you wanted to, so
Yeah.
that would be a very, it'd be an scientifically interesting study, but it also have practical implications. So,
Mhm.
and seems
What other
like,
support? Well, my mind clearly goes to incentives. That's a tool that we know works. But are there other types of support that we could also provide to get them closer?
yeah,
Yeah.
but
Yeah. This is a very,
it's-
I mean, I agree. It's a very powerful finding.
scientifically, you could, at a practical level from what we know already with CM and monetary reinforcement, you could run that study. I don't know if there's a ceiling. Maybe there's no amount that would get you up to the equivalent of varenicline in a population without mental illness, but perhaps there is.
Yes.
And that would be, if it's not too expensive.
Yeah, I kind of regret that I did that study with bupropion and CM, and then I got involved in very low nicotine cigarettes, which took me on the whole regulatory path. And I
Right.
never really followed up the CM plus meds.
There's always a future.
More grants to write.
Yeah, we have a question here. Yeah.
Hi, Jen. Thanks for your talk. Katya Nolder, postdoc with Steve. I just had a kind of a two-part question. When you showed that pie chart with the amount that individuals with serious mental illness would spend on cigarettes,
Yeah.
is that how much they would be willing to spend on cigarettes?
No,
or
that's how much they spend.
how much they do spend. And do you know if that differs from like a
Trying to find
control
it.
group, or if that's similar to the amount that people generally spend, or is that more specific to people with mental illness?
We could do that because we have those data, but it's not, sorry, folks online, especially, I can't find the slide, but I
It's
think you
okay.
can all remember, it was like 25%,
Yeah.
27%. That's Mark Steinberg's study. He didn't do a comparison of people who smoke without schizophrenia, and I haven't looked at it, but we have the data. We could look at it. We can do that.
Yeah. Yeah.
Yeah,
I was
because
just
we
wondering.
always ask people their income and how much do you spend on smoking? So
Gotcha.
could be done.
Thanks.
Questions, comments?
Yeah.
Another question here. This is a very practical question. So, I noticed in some of your earlier slides, people separate mental health conditions by DSM-5 diagnosis or DSM diagnosis, and then sometimes just by symptom severity.
Yes.
So, conducting secondary analysis, and if we're lucky enough to have a large enough sample size, how do you recommend we start to split up mental health conditions to look for differential effects, like by severity, by diagnosis?
So Diane Galima did an analysis where she looked at symptom severity by diagnosis. I think it was depression symptoms that were driving a lot of it, symptom severity, especially depression symptom severity, rather than diagnosis. But yeah, I thank you for raising that, because I wanted to say this is like, it's such a big topic, and we sometimes gloss over some of these details. Is it diagnosis? Is it the symptoms? You know, what is it that we're looking at? And not to mention that the studies often include, you know, SMI in general, not necessarily schizophrenia, and there are a lot of different subtypes. So unfortunately, that's just sort of a factor of the size of these studies and getting this work done. But yeah, maybe with the T-course studies, we do have enough power where we could look at that.
Thanks.
There's a question over there. Steve, there's a
Online?
question.
Yeah, why don't you take that one and then I'll do this.
Okay. Oh, yeah.
So I was curious because the percentage graph that you showed up earlier is, were you guys able to record, or do you guys notice any correlations between economical situations? Because I know that there's a lot of correlation with mental health and poverty and all that circumstantial stuff. But I was curious if there's a correlation with that and smoking as well, because I do know there is one with drugs as well.
Yeah, absolutely. And that's another caveat to all this work, is people have multiple things going on. So we focus on their serious their diagnosis, or in some case, their symptom severity. And we're not necessarily covering or even thinking about socioeconomic factors that are absolutely, people with socioeconomic disadvantage have higher smoking rates. And how much is that accounting for what we're seeing in these studies? Yeah, thank you for raising that.
Okay, we have a question online from Sean. He says, I may have missed this, but do you see any differences in wanting to quit, such as the contemplation ladder? Certain disability groups attempt to quit at equal or higher rates, but have difficulty with the quit attempt.
Yeah, what we see is that looking at motivation to quit or wanting to quit is very similar across people with mental health conditions and people without. It's the success rate of that. Again, which could be due to not having access to really effective treatments, or the kind of thing I was talking about in this talk, which is the efficacy of smoking reinforcement versus other reinforcers and costs.
Great. Any final comments or questions? Well, we're just about out of time. So Jennifer, I want to thank you for a wonderful presentation. It's such an important and interesting topic, and something we need to do better at, helping people with mental illness reduce or quit smoking. So thanks very much. And thanks to the audience online and to the folks who are here with us. So that wraps it up for today.
Okay, thank you all.